Let's begin by putting some clinical perspectives into the midgut and hindgut anatomy. This is a really long presentation as usual, so I broke it up into 3 parts to make it a little easier for you to digest. So we have several learning objectives, and maybe we can go through and answer some of these on our way through them. I'd like you to recognize the normal appearance of small bowel and the colon on endoscopy, laparoscopy, and radiological images of the midgut and hindgut. We got to talk about the various types of colon polyps and how they're managed. We need to identify some of the most common pathology of the midgut and hindgut via their endoscopic or radiological images. We also need to list several colon diseases which lend themselves to radiological and or endoscopic interventions and discuss the management options of them. Also, I did put a little brief booklet here, and I'll include that with this PowerPoint, colonoscopy for dummies, because I know your family's going to ask you about that at some point. Also, we need to discuss the indications and limitations to the various small bowel and colon studies that are available to patients today, including but not limited to interclysis of the small bowel, what it is, and a small bowel follow-through, what it is, how we do it, why we need it, capsule endoscopy of the small intestine, dephography and anal rectal manometry, not very commonly used, angiography, a tagged red cell scan. We're going to talk about colonoscopy and how it can be used for biopsies, stenting, diagnosis, and fulguration or cauterization of polyps or lesions. Obviously, we have to mention CT scanning of the colon. We're going to talk about how the transverse colon looks on a colonoscopy and how that is very easy to identify where you're at when you're doing a colonoscopy because of the triangular appearance of the transverse colon. We'll talk about virtual colonoscopy, what it is and how it's indicated. We'll also talk about gastrographin enemas, hypaque enemas, and barium enemas, what the difference is and why we still use them. In addition, what's the most common cause of a small bowel obstruction? Well, the answer is adhesions from previous surgery. What is a Meckel's diverticulum? You've heard about that already from your embryology lectures. It is a true diverticulum, and it's a remnant of the vitellin duct. What are jejunal diverticuli? What's an internal hernia and what causes them? What's the most common cause of appendicitis in a child? Usually, it's lymphoid hyperplasia. In an adult, it's usually a fecalith, a piece of poop that gets stuck into the appendix. What is Hyde syndrome and what is its treatment? Hyde syndrome is relatively rare, but it is something that may haunt you. Hyde syndrome is multiple arteriovenous malformations that occur all throughout the GI tract in patients who have aortic stenosis. And they can literally bleed to death from Hyde syndrome. And the treatment, you have to fix the aortic stenosis and the arterial venous malformations, the AVMs, or the angiodysplastic lesions, go away. What's Ogilvie syndrome? It's another name for something called colonic pseudo-obstruction. How is it diagnosed and how is it treated? We'll talk about that. What is Crohn's disease? What's ulcerative colitis? How do they differ and how are they similar? I know you've gotten this information in your pathology lectures, but we'll touch on it again. Also, you need to figure out what is Clostridium difficile colitis. How do we recognize it on endoscopic imaging? How do we recognize it on CT imaging? What's its cause and how do we treat it? We need to differentiate among endoscopic and virtual colonoscopy, as we just mentioned, barium enema examinations, what they're indicated for, and what are some of the complications of using gastrographin, hypaque, or barium sulfate. Some required reading, which I have attached, is mostly about acquired von Willebrand syndrome and aortic stenosis, otherwise known as Hyde syndrome, with the associated correspondence that it generated. So here's a good example of an image for enteroclysis. So here's the learning objective. Discuss indications and limitations of the various colon and small bowel studies today, including but not limited to push endoscopy, interclysis, and capsule endoscopy. Interclysis is where we insert a tube into the small intestine and we pump barium or gastrographin contrast material into the small bowel so we can get a good look at all of the valvulae coniventes here, these small folds within the small bowel. Why would we do an interclysis? Why would we put a tube down and have to pump the small bowel full of contrast medium? Well, maybe somebody has a tumor or a small bowel obstruction and we don't know what exactly is causing it. They could have a lipoma, they could have a large polyp, they could have cancer. The other way to do this is what's called push endoscopy, and we'll talk about that. That's where an endoscope is actually inserted into the stomach, the small bowel, and it has two balloons on it. We'll see that here in a video. So this is push endoscope. This is a endoscope that has two balloons on the end of it. And let's see how this is used. Hopefully I can bring this video up and it'll show.
Smart Medical Systems presents the NaviAid BGE, a balloon-guided endoscopy device enabling small bowel endoscopy with your existing scopes. The NaviAid BGE device comprises an add-on disposable two-balloon element and an air supply unit. The NaviAid air supply unit is placed with any standard endoscopy console, with its indication panel indicating the balloon status located near the monitor. The BGE disposable is easily mounted on the tip of a standard endoscope, with its front balloon sheltered within its rear balloon. The front balloon is advanced or retracted manually. It propagates within a dedicated external channel, leaving the endoscope tool channel free. The balloons are operated by the dual foot pedal of the ASU. Advancement is achieved by sequential balloon operation. A BGE procedure begins with the endoscope being pushed into the small intestine as far as possible. Deeper advancement is then achieved by sequential BGE steps. A BGE step begins with inflating the rear balloon to anchor the endoscope tip to the intestine. Then the deflated front balloon is advanced ahead of the endoscope and inflated to anchor it to the intestine. The rear balloon is then deflated and the anchored front balloon is pulled while the endoscope is pushed through. As the endoscope reaches the front balloon, the rear balloon is inflated and the front balloon deflated. Subsequent steps are performed as needed, advancing the standard endoscope deep into the small intestine. Following a BGE step, the endoscope may be pulled and shortened with the rear balloon inflated. The NaviAid BGE affords low-cost and superior small bowel diagnosis and treatment. Fast and efficient advancement is facilitated by a highly flexible advancing tube and by efficient intestinal insufflation. Simultaneous balloon inflation allows fluid application through the endoscope tool channel into the sealed intestinal volume. Air insufflation may provide better visualization of the lumen. An inflated front balloon may be used for accessory counterforce or positioning. Alternatively, the front balloon may be sheltered. The NaviAid BGE is FDA and CE approved and is already in use in clinical practice. NaviAid BGE.
Here's something called the pill cam, which is a capsule endoscope. This learning objective is to discuss some of the indications and limitations of this procedure. Well, first of all, this can get stuck distally into the small intestine. They're actually not that small. It has a camera in it, and the person actually wears a jacket that has radio frequency sensors on it, so we can tell where in the intestine the pill is at. Why would we use this? Well, if you don't have the ability to use enteroclysis or the ability to do push endoscopy, you might ask your patient to swallow this mini camera. Anyways, it is swallowed, and it takes pictures all the way down up to the point of the obstruction. Let's take a look.
Hey guys, it's Jackie. In today's Innovation in Medicine, we're talking about a new technology that is changing the game when it comes to getting a colonoscopy. I'm here with Dr. Estrada, and Doctor, this is actually a pill.
Yeah, that's right. It's a pill that can actually take pictures of your intestinal tract as it passes through the system. It has 2 cameras on either side of the pill, and you swallow it. And by swallowing it, it starts taking pictures throughout the entire GI tract.
That seems very different from the traditional colonoscopy.
Yes, a traditional colonoscopy, you have sedation with anesthesia. Your doctor will put a flexible camera into the body and take a look to see if there's any abnormalities. This one, you still have to take a medication that cleans the colon so that we can see clearly, but you don't need the anesthesia. You don't need to take time off of work. You don't have any recovery time. In fact, a lot of patients will take the pill at the doctor's office and then go on to their day at work.
Tell me about how the doctor is seeing those images that are coming from the cameras on the pill.
It takes 360-degree images as it's traveling through the GI tract. Those images are then transmitted to a recorder about the size of your cell phone that you wear on your waist. And then once the pill has passed, it'll pass like any other stool bowel movement. You can flush it. It's not going to disrupt your plumbing or anything like that. And then you take the recorder to your doctor's office and they can view the images.
So there are a lot of benefits to this technology, but it doesn't necessarily replace a traditional colonoscopy.
The advantage of the traditional colonoscopy is that not only can you detect an abnormality, you can remove it. The disadvantage of this technology is it only detects it. So if there is an abnormality detected, then you'll still have to undergo the colonoscopy. The advantage, though, is if you do have an abnormal pill colonoscopy and you're at the same day, you can go and have your colonoscopy because the colon has already been prepped.
So why is this such an important innovation in medicine?
It certainly is an additional tool that a doctor like myself can use. It's perfect for patients that can't tolerate anesthesia or have had incomplete colonoscopies in the past. So if they were unable to do it because their colon is quite long or is very difficult with a traditional colonoscopy, this will allow the pill to go through all those loops and bends. Colon cancer is the second leading cause of cancer deaths in the United States. It's very common. In fact, 135,000 patients will be diagnosed with colon cancer this year. And the best way to prevent colon cancer is through a screening protocol.
Thank you, Dr. Estrada.
Thank you.
And for other innovations in medicine, head to our website, livinghealthytv.com.
Here's an example of PillChem going through the small intestine. And here you'll see that the camera actually finds a narrowing called a stenosis that the pill itself can't actually go through. And this time there's a polyp found within the small intestine. So here is actually it looks like a large lipoma, a benign fatty tumor in the small bowel. This could cause an intussusception or a folding of the intestine on itself, just like a antenna does on an automobile.